Good morning. My name is Marie Gascoigne. I'm a speech and language therapist, and I lead Better Communication Community Interest Company, which is a small not-for-profit organisation that supports our children's system in changing towards being more accessible for children and young people and their families. And we in particular use the framework that I've been developing over 20 years now, which is called the Balanced System. And I'm joined today by a colleague from Lancashire, who I'll hand over to in a second to introduce herself, but we are representing a wider group of people today, including Emma Jordan, who leads the Speech and Language Therapy Service in Worcestershire, and some of Emma's data is in this presentation as well, which I will talk to, and Dr. Alison Moore, Public Health Specialist, who has been very closely involved in driving the change that Claire will describe in more detail. So I'll let Claire introduce herself, and then we will get into sharing our information with you.
Hello, I'm Claire Neal. I'm a consultant speech and language therapist and Associate Director of Allied Health Professionals. I work in Lancashire for Lancashire and South Cumbria NHS Foundation Trust.
Thanks, Claire. Okay, so in today's presentation, we're going to go through the context for why we might want to organise our service delivery in a different way, give some key examples of where this has led to easier access, and then focus on a recent case study, which will be Claire's case study, introducing community-based easy access walk-in sessions as an alternative to traditional referral processes. I'm just going to move this widget out of the way there so that we're not in the way of our slides. There we go. Okay, so I'm going to start by going big picture and think about the system challenges that we face as a community trying to support children and people at the current time. So we've seen over the years continual policy changes. Some have been helpful, some have been less helpful. Structural changes in local authority and health organisations, including the formation recently of the integrated care systems and the churn that that's made as CCGs have ceased to be in existence, and that move has happened. Obviously, the impact of the COVID pandemic, which is becoming more and more evident as more data comes through around the children, particularly the children in the early years who were impacted by COVID lockdown and lack of opportunity, increased referrals and emerging evidence of increasing need in the population, increased waiting lists and waiting times, which is a particular concern at the present moment, and a pressure to focus on specialist inputs at the expense of early intervention and prevention systems that can enable access to specialist support. And that's really where we're focusing today. In our view, there's an overemphasis on the waiting list and inputs as metrics for change, and we should be looking more at outcomes that are around impact and being easier for people to access. And all of this sits in a reality that there is a difficulty nationally in recruiting speech and language therapy colleagues at the present time, so that needs a bit of creative thinking as well. However, there's some enablers in the system, which is good. So the increased awareness of the importance of early language and communication and the impact on those long-term trajectories is much more known about at a policy level and more generally across our colleagues across the system. Supporting children and young people with speech, language and communication needs and their families is increasingly recognised as a priority for local authority early years, SEND, schools and settings, as well as health systems. And there is an increasing understanding and interest in population need and building co-design systems such as the one that we're working with in this example. Just to give a bit of wider context, I've pulled some documents that thread this way of thinking from its infancy, going back to 2003, right up to this year, 2023. And the core elements that we're going to be talking about, or that sit behind this, we're actually obviously focusing on one particular element today, run right the way through all of these documents over this 20-year period. So I guess the message is it's not new news. And the reason it's so important, I'm pulling out from one of those documents, and all the links to the actual papers will be through the PDF of this that you can download. If we don't get it right by the time a child is 5, we have really good evidence that the impact will be seen in later life. It'll be seen more immediately in terms of outcomes, educational outcomes at 11, as you can see there. It'll be seen in terms of social outcomes, but also long-term outcomes in terms of employment and mental health and well-being as an adult. So this is really something we have to keep banging the drum about, which obviously we do as a speech and language therapy community, but actually we really do need to understand that we are confident about this data and how important it is. The Best Start in Speech and Language and Communication Guidance around early years that was published by Public Health England just towards the tail end of COVID recommends having a systems framework, and within that document the balanced system framework is referenced as a good example. And here is just to highlight the structure really, which is that if we're working towards this model of delivery, what we want to have as a result is that we are able to say that these outcome areas across these different strands of family support, environment, workforce, identification, intervention are all being realised across a continuum of universal targeted and specialist support. And recently we've also found that there's been a positive connection with these wonderful pair of papers here by Sheena Riley and Christine McKean around looking at that evidence-informed public health approach. So there's a lot of evidence emerging in terms of this being a good thing to be thinking about and challenging ourselves with. In terms of moving towards making it happen in an area, which is what we're going to focus on today, we've pulled through 5 key delivery principles that seem to be the game changers in terms of changing a system. So the whole thing is about being outcomes measured, and measuring those outcomes through impact measures, and that counting things is not necessarily a particularly helpful metric. We're not going to talk about that today. We want to have this trio of principles in the middle there to do with being easily accessible for families, being place-based where children functionally use their language and communication skills, and making sure that there is that targeted approach, a robust targeted offer sitting between that continuum from universal through to specialist. And that's particularly important if we're going to shift the system. And the diagram on the left is from one of those earlier documents, and it's actually from a Worcestershire example where a commissioner presented it back to their own group by saying we end up with this vortex through to specialist if we don't have that robust middle. And the information part is about making our information also accessible, but we're not focusing on that today. So in this presentation today, we're going to focus very much on the access element and moving away from that refer, assess, treat paradigm, that traditional linear model of a child being identified by somebody in the community or a parental concern, but then having to go through a formal referral process and then having a booked appointment for an assessment and then going through a process and then, if necessary, going into a treatment opportunity, as opposed to thinking, can we be more responsive? Can we go upstream? Can we predict where we might want to be offering opportunities for early conversations and early opportunities for families? And that's the focus of today's work. So that access principle I've just described is around making sure we have that early identification through giving the right information, assessment and support. Easy access, so being as simple and easy to access for families as we can be, and what that means. And that might mean different things in different places. If you're in a very rural area, that might mean doing that in one way. If you're in a bit more urban area, it might mean doing it a different way. And that making sure that our assessment processes are inquiry-based, that we don't feel the need to do a whole predetermined set of assessments before we can reach a conclusion, but we actually use our expertise to look at the child and family in front of us, and if we can immediately signpost to something, we do that, even if we need to continue to inquire further into the child's needs and profile. So I'm going to just put this in the context of talking walk-ins and open access sessions specifically, because that's what we're going to focus on as an example today. But this is obviously not the only thing that you would do in terms of being accessible. But just to give again a sense of that history, the very first talking walk-in in the country, I'm pretty confident in saying, was in the children's service in Hackney, which I was working to transform back in 2003, so 20 years ago. And there you have the original talking walk-in poster, but underneath you have a screen grab from the current website for Hackney, the Hackney service, Hackney City Service, which basically still describes that offer. So in 20 years, that offer has felt to be appropriate. And although it's morphed in terms of response to external factors such as COVID and so forth, it's still happening. In the data we're going to talk about from Worcestershire, that I'll just briefly overview from Emma's contribution to today's presentation, shows a longitudinal set of outcomes and data based on their transformation to the balanced system in 2011. And they're still going. We've got an example that we're not talking about today, but Forth Valley in Scotland, we did a lot of work with, and they are featured as a case study in Equity for All, which is the Scottish Government report that I wrote 2 years ago. And so that's a good example there of a Scottish service. And then Claire's obviously going to talk about the Lancashire example. And we've got other areas that are busy working towards transformation in terms of their delivery as we speak. Okay, so this is Worcestershire data. And what we wanted to show here was the longitudinal sort of patterns, if you like, through moving away from this refer, assess, treat paradigm, but into a more open access opportunity. So in terms of the early access data from Worcestershire over the years, what this graph is showing is that the proportion of early access goes up in terms of the early years proportion relative to the school age proportion going down over time. And we see that as a positive indicator that children are being able to access support and advice and whatever it is they need sooner. So that's one metric over time, over years. In terms of the actual granular age within that early years piece, what you see here is a sharp increase in the number of 2-year-olds that are being referred or are accessing that easy access opportunity as the system matures. So the walk-ins were introduced in 2011, and you can see there's a slow takeoff there, but a really quite sharp increase in the number of 2-year-olds relative to the rest of the age range. And you'll see again that yellow line, the 4-year-olds going right down as a proportion of the preschool children. So that's another metric in terms of getting in sooner to actually have those conversations. And this is perhaps the most remarkable slide, and this is mirrored in Claire's data later on a shorter time frame, but over the whole journey, and we've just taken a sample here from 2011 to 2019, the percentage of children waiting over 18 weeks at the beginning when the model was first introduced in Worcestershire was 26%, which dropped dramatically and quickly down to something hovering around 2 to 3%, and it stayed at that level all the way through to the current day. So I suppose what we're wanting to demonstrate with this longitudinal approach is that this has got sustainability over time, and it doesn't have bumps that then go right the way back up again. Okay, so the key messages from Worcestershire that Emma's asked me to share on her behalf were the service transformation using the balanced system had a significant impact on access to provision, both for early years and school age. Obviously, we're not talking about school age today, but Worcestershire implemented the system across the whole age range. And the impact of the talking walk-ins in the early years was evidenced in both a reduction in the longest waits and percentages waiting over 18 weeks, and the maintenance of this position over the subsequent years. And the percentage of children accessing support for the first time in the early years also increased relative to school age. Okay, so I'm now going to hand over to Claire, who's going to describe a more recent piece of work in a much shorter time frame, but actually what we wanted to demonstrate is that the pattern of change is similar. Over to you, Claire.
Thanks, Marie. So in Lancashire, we moved from a traditional model of assessment to an instant easy access in one area in one of our teams. November last year, we held a waiting list, sent letters to parents to invite them to make an appointment, held individual appointments in a clinic setting, and waiting lists were really long. So I think our longest wait at that point was 42 weeks. So the time felt right for a change to this approach. And we were really galvanised by public health leads who were really motivated to move to a different system. We built on a training programme that we were delivering targeted support into nurseries to help them support children who had difficulties with SLCN. So we were working across the core delivery principles that Marie has formulated. We met with colleagues from the council, from libraries, children and family wellbeing services, advisory teachers that went into nurseries, and devised a whole system walk-in, which began on the 2nd of December 22. And in this, parents could access SLT, but also health visiting, library services, children and family wellbeing. And according to the Balanced System needs analysis tools, we knew that children in a particular area were particularly vulnerable to SLCN. And so we chose the park, which was a children's centre, very familiar to parents. Parents were already accessing this place. We wanted to create instant access at the same time as tackling the waiting list. So we basically divided the morning up, and the first half of the morning we would see children from the waiting list. The second half of the morning was dedicated to children who had just in their health visitor that week, and the health visitor had informed them about the walk-in. Children who attended were very briefly assessed according to the level of demand on the day, and signposted towards specialist, targeted or universal support. And parents went away with a report written with them in the session. This was a bit of a challenge when we had kind of 17 to 20 children, but less of a challenge when we had 4 or 5, and there was no way of predicting who would turn up on the day. So this slide just demonstrates some of the data we collected. It talks about the length of time that children had to wait. When we began holding walk-ins, you can see that we had children waiting for 40 weeks for intervention. And at this stage, there was about 150 children waiting on a waiting list. You can see from this graph that we dramatically reduced the waiting times so that by March, children were only waiting 5 weeks. On this graph, you can see the total number of children attending per month, as well as the level of intervention that followed their attendance in walk-in. So the navy bar, children assessed as needing a specialist level of intervention at that time, and they were provided with a follow-up appointment or appointments if they needed it. The green bar were children that we thought needed targeted intervention, and that was the training that we put on for nurseries to deliver groups to accommodate those children. Some children who were demonstrated there in purple, we felt that their needs could be met by access to universal provision. So chat, play, read groups, libraries, and of course we'd give them support and advice on developing their children's speech and language and communication. And because we made a commitment to attend every week, we could reassure parents and say, look, this is what we think is going to work for your children. But if you find that it's not working, you can come back. We'll be here every Friday. So thanks, Marie. This slide just kind of demonstrates the transfer of children from the waiting list to walk-in. So right at the beginning, you can see that there were about 50 children per month attending from the waiting list. But then as time went on, we got more children attending from the pure walk-ins. So outcomes, I was really keen, and so were my system partners, that we evaluated this really well. We tried to evaluate it in different ways. So there was data from health visitors about who they'd referred and who actually attended. There was data around the training that went on in nurseries and how helpful people found that, and what the potential reach of that training was as well. In terms of attendance from the waiting list, we got 55% attending, but every child that didn't attend got invited to subsequent walk-ins, so we weren't particularly concerned about that. One real advantage of this model, and something that's really difficult to capture, is the holistic support that families received. So they got advice on their speech and language, they got support from the speech and language therapist, but the other people in the room were able to support that family in a more holistic way. And so they went away with sometimes an SLT appointment in the following weeks, but sometimes they were intending on attending chat play read groups and even stuff around domestic violence, anything that was relevant to the needs of that family at that time. But one of our most successful evaluations were our parental evaluations that wasn't actually led by the Speech and Language Therapy Service. It was led by Public Health. They collected this data that Marie's just going to talk through now.
So indeed, Public Health colleagues in Lancashire collected this data, and we have put it through an analysis using our Prove It tool, which is in development at the moment, in order just to kind of analyse at a glance really the 209 responses. So what you'll see here is that some of the questions that were asked and the response data, this is on the day. So how easy has it been to get advice about your child's speech and language? You can see overwhelmingly positive outcomes reported there. How helpful was the advice? Again, positive. Measures of confidence about the advice that they've been given being helpful and that it will be helpful, and ensuring understanding of what the next steps that have been recommended are. And this is particularly interesting in terms of where we're up to at the moment. So this is putting the open-ended questions and responses through the AI that we've built into the tool. We're still working on this and developing it, and we noticed that the AI has reported the respondents as being citizens, and we would probably want to rephrase that as families and parents. But what you'll see here is it's picking out some core themes very clearly in terms of going away to use strategies and advice to seek opportunities for group activities, implementing tools and techniques that have been recommended, and encouraging and praising clearly being a common theme of what's been recommended by the therapists in those interactions. And there's a bit more detail in those speech bubbles. In terms of what could make it better, what you'll see here is that there was an overwhelmingly positive response to the opportunity, and that families really were just very, very pleased to have this opportunity. So that's trying to start to build a data set, I guess, that we could then go back to, because if we were using this with families in a future iteration and they shared their information, you could then automatically trigger a follow-up question. It could be on a text or an email to say, and how's it going now? But as Claire says, the beauty of this approach is if you're part of the community system, you're known to be there, and that takes a huge amount of anxiety out of the parental space, just by the fact that they know they can just go back next week. So this is us. We'll just conclude by sharing our contact details, and we're all very happy to be contacted if people have further questions that they want to ask.